This is the throwing shoulder, what we've learned, especially we focus this on retrotorsion and GERD, because those are two buzzwords that we need to understand about throwing. So we start there, but we didn't talk about those things 20 years ago or 10 years ago, but now we do. So these are our disclosures. Most of my disclosures are related to foundation support. So people say, let's do something, and I'd say, okay, but why don't you give the money to our foundation? So over the years we've done that. That's how we've raised money along the way. This is Aldous Chapman. So that's 105. That's about the fastest fastball in the big leagues, 105, 106. I've seen him throw 106. So that's pretty fast coming at you as you're a batter. So you'd wonder why the arm is capable of doing all that and what it means and where he gets all that kinetic energy and how he throws. And if you look after baseball at the professional level, a lot of us won't do that, but those of us that do, you learn certain things about shoulders and elbows. That's why it's fun. Football is more fun because they have all kinds of injuries. I looked after the Broncos for 15 years, and you're always doing different things. But baseball is very select, and it's also very boring to cover a baseball game because you have to go down and work out or do a paper. Football, you have to be right on the sidelines all the time paying attention. So baseball is fun because of the shoulder, elbow injuries that we see. Not that we want to see people get injured, but it does teach us a lot. So sometimes we can extrapolate that down to college, high school, and so on. So we're going to talk about pitching mechanics a little bit, not much, humeral retrotorsion, range of motion adaptations that you know about, GERD will define, and the scapula plays an integral role in all this. And if you think about internal impingement and slap lesion and throwers, you probably got the majority of the diagnosis, pathologically. So anyway, impingement and slap, those are the pathological, but there's a lot going on that relate to that. There's the range of motion, GERD, scapula, and all those things. So they sort of tie into what throwing is all about. So we years ago, this is probably 30 years ago, we worked with that team on, this team here on the right, particularly Sherry Werner and Mike Decker, Michelle Shaver. These were all PhD people in our lab in Vail, Colorado. And we started then looking at throwing. You can see the camera set up on the right here, where Sherry Werner would set up cameras at home plate, first and third, and we'd look at pictures and we'd digitize those. So we'd put markers on the skin to see what the motion was about. Motion is kinematics, forces are kinetics, and so we sort of analyze them that way, which is a crude way, but an okay way at that time to analyze how pitchers throw. The true way you look at kinematics in the shoulders, you put pins in the clavicle, pins in the humerus, and do it that way because you have more accurate analysis. But putting markers on the skin, not so accurate. But we did that for many years, and as a result of that, we published a large number of papers out of that. So these were the landmarks, and we did these statistical thing, which Chuck and some of you know about, regression analysis and what have you. So then we started to publish papers based on our going to the Rockies and looking at pitchers. So we have access to the minor league teams, which is probably about how many athletes, Chuck? 200 more? A lot of 80 or 90 throw pitchers, and we do the big league too, but they're a little separated. Although Rockies are trying to bring them together. Most teams keep the minor league players and the big league players very separate. But Rockies sort of have them pretty close now. It's much more collegial. At any rate, this was Young Kyu Kim from Korea, came here for a year, JT Tokish, you know. So this was looking at humeral retroversion, which we now call humeral retrotorsion. Retroversion, if I might suggest, should be applied to the glenoid, therefore retrotorsion to the humerus, which keeps it distinct and sort of better defined. And then you see Michael Torrey, Michelle Sabak were PhD students, and Mike Curtin was our doctor with the Rockies many years ago. And so we had this radiographic method of how to measure retrotorsion in pitchers. and you don't have to know the particulars of that, but it was a little bit complicated. Now we can do it more effectively with CAT scans, and in fact now Chuck and Ellen have an ultrasound or that goniometer thing, and they can do a lot of things in a pretty simple and quick basis, which we'll sort of show a little bit. So what we showed when we looked at this, and the first people to publish this paper was Jimmy Andrews and Herbert Crockett. What we saw that the throwers have 18 degrees more of external rotation than the opposite side. They have a correspondingly 18 degrees less of internal rotation, so we know that. And we measured their retrotorsion, we call it version N because that was the old days, and their retrotorsion was 11 degrees. So that retrotorsion contributes some to this range of motion. And we'll sort of come back to that. So it's interesting with throwers, if you think they got low, and you analyze them down here, they're the same. But they're not the same up here. Dr. Mallon, this is external rotation maybe here. Dr. Mallon says this up here is not external rotation. He calls that elevation. He's a mathematician. He says, no guys, you're not measuring external rotation up there. But anyway, so that's confusing. You know, Codman's paradox is that if we do one plane motion with our thumb straight ahead and go up to here, and then we do one plane motion, horizontal adduction to here, and then we come back down to here, then we've rotated between here and here through here 90 degrees, and we didn't see any rotation. And that's called Codman's paradox. In Campbell's orthopedics, they talked about fusing a shoulder in, they show a picture, 35 degrees of external rotation. But if you bring your arm down to your side, it's 35 degrees of internal rotation on this measurement. So you can see the confusion about this paradox that we have. And so it's not simple to understand all these things.
Your shoulder working okay.
This is the one you fixed. Michael put a artificial shoulder in my right shoulder. How long now? Year and a half? 2 years? Last thing when I went to sleep, I asked him not to screw up on the subscapularis, which is pretty important. And he didn't. I play tennis now with this. Play tennis. Subscap is, I don't think ever regain, I don't think ever regain full subscap strength. But I can serve anywhere in the tennis court, I just can't serve very hard. And I can't shoot the three-pointer anymore. Maybe I never could. This was a paper by Schickendance, one of my fellows, about the throwing shoulder. So we talked about a lot of these issues. So these articles in the AAOS journal are great. And they take subjects and they deal with them, and this was a good one we did here. So if you look here, you can see these are all publications we did talking about if you throw the ball, the human head is distracted from the socket. Those are distracted forces. And these forces we measured were the highest of anybody because all our pitchers were professional. Jimmy Andrews and others have published, but they've done all college kids and others, so it's a cross-section. But ours were a select group of professional pitchers. So our forces were actually higher. So we looked at effects of extended play between the first inning and the sixth inning and how ball mechanics changed. While some pitchers are throwing 5 miles per hour slower than they started at the beginning of the game. As you know, that's why a starter, about the sixth inning, they start to hit them and trouble starts. Elbow valgus torque is fascinating. We'll come back to that at the end of the talk, but there's, as you know, when you're up here throwing, there's a lot of torque on the elbow. And in fact, the stress on the elbow, force-wise, should rupture the ligament with every throw. It exceeds the strength of the ligament with that position, but because of the joint configuration and other structures, it doesn't. But you know how common ulnar collateral ligament tears are. I mean, probably half of big league pitchers have had a UCL, maybe half. I see that Japanese kid is just going to have one. So it's pretty common. If you want to have an injury in the big leagues, UCL is a pretty good one to have. But don't have a shoulder injury. That's a bad one to have. We're not very good at that. And velocity related to the elbow, as we talked about. Then we kept going in all these. And these are all, now we're moving farther along. Werner was back in 08, and then Tom Noonan, who's a team doctor now with the Rockies, and Chuck and Ellen came on board. And then we talked now about GERD, risk factors, and the thrower shoulder. So we're now publishing more papers. So I don't know how many we published on this, but a lot. And this is interesting on youth pitching studies. So youth is pretty similar to adults. Of course, they just don't have quite the forces. but it starts way back then when we think about what's going on with this GERD. So this is something you've heard of, and particularly in the South and in the senior leagues, about athletes in their 40s who pitch, and with one pitch they fracture their humerus. They spiral fracture their humerus. And this was one ex-pro pitcher that this happened to. It just shows his picture. And there are many case reports. So that sort of made us think a little bit about the model of what's happening in the humerus with throwing and why we have this torsion effect that occurs. And this was Michelle Sabeck, who left Vail and is in Boise with Mike Curtin. Is he Boise, Chuck? And she's a bright, bright girl. But she, if you look at the arrows up there, you can see at the proximal part of the humerus and the distal part of the humerus, their forces are in opposite direction. So, and we'll come back to what surgeons miss, but it creates a situation, not that it increases retrotorsion, but it slows down the development of antitorsion. So it doesn't increase retrotorsion, it slows down the development of antitorsion, so therefore you end up with more retrotorsion. It's a little confusing, and I apologize for that, but we'll come back to that in a bit. But that's a model that I think that she described and I think is pretty good. So anyway, this is a child, and you can see we take pictures on each side, and the epiphyseal plates are widened, and they have shoulder pain, and they have this epiphysitis, if you will. And if you look at this slide shows it here, that aging in utero, we have about 80 degrees of retrotorsion of the humerus. And then as we become little people and grow a bit, it starts to come to normal, getting toward neutral in normal people. But it stops at about 15 degrees in the thrower because of those forces we talked about if they throw. So it's not that it causes increased retrotorsion, it just slows down the development of antitorsion. So lots of people don't quite understand that. But this starts in youth, so it's way back then. So if the bone is mature, then we're not going to cause torsion in the humerus because we can't twist the bone, although those forces are the same. We could spiral fracture the humerus. But if they're children, when the bone is sort of plastic and the epiphyseal plates are sort of malleable, then it can have an effect. So this is developed when they're younger. A guy named Bill Carson popularized this at least 30 years ago when he talked about it. And then Arun Ramappa, one of the professors in Boston, sort of looked at this. And so this is called the little leaguer's shoulder, which we see. So we see a 12-year-old kid come in with open epiphyseal plates and they got shoulder pain, and we say, well, you probably got a little leaguer's shoulder. That's when they're starting to the bones are twisting or slowing down, and they're twisting, and we usually shut them down and keep them quiet, and they're okay. They get back to throwing by and large. So this was the Crockett, Heber Crockett, that was the name, I'm sorry, and Kevin Wilk, who was with Jimmy Andrews down in now Pensacola, was in Birmingham. But this was the first paper with a CT analysis looking at the bony architecture, and just summary that you all know. So the pitcher has more external rotation and less internal rotation on the throwing side than the normal side, but it's the same arc of motion. So I think you all know that. But that's important to understand. Now what we have to feed into that is, well, what role is retrotorsion, i.e. the twist of the bone statistically, playing in this motion? So if they have a lot of retrotorsion, they have more external rotation and less internal. If they have less retrotorsion, then they don't have it. So it's important to understand the role of retrotorsion in all this. And we'll come back to this at the end. So this was the first good publication that did it with CT scans. And this is Chuck and Ellen, who now are doing their transducer to look at, with an inclinometer to look at how we do it. So Chuck and Ellen know as much about throwing and biomechanics and injuries and so on as anybody in the world. I mean, we've looked at countless number of throwers at the high level, and that's where we see them. Chuck was working, I came down to the clinic yesterday, I was working with a Kansas City Royal AA pitcher, big 6'3", good looking guy. And so the guy's come now to sort of for analysis and treatment, if you will. So now this is looking at humeral torsion. It relates to the bicipital groove and then the axis, and so now we can measure retrotorsion with our transducer and ultrasound, but the bicipital groove is sort of the landmark to say how much retrotorsion they have in the humerus. Remember I said it's important to know as we think about range of motion what the retrotorsion is. So we'll come back to how that relates to injuries, more or less retrotorsion, more or less motion, and so on. So this is just showing the inclinometer and how it's done. Here's an interesting thing. This is Pearson's coefficient. And so my understanding is what this says is that humeral retrotorsion is related more to loss of internal rotation. And the gain in external rotation is related more, relatively speaking, to soft tissue. So it's just sort of an interesting feature. And so pitchers with an internal rotation deficit display greater humeral retrotorsion. So not to confuse you, but it's sort of important. Now, GERD, what is GERD? So if we have more external rotation, less internal rotation on the throwing side, we wish we were left-handed, but I did it on the right. And so here we go way back here. Here we go to neutral. So 20 degrees more here on the throwing side. And then we come down here, and we're 20 degrees less, but you see we got the same arc, 115 degrees, 115 degrees. When the pitcher starts to lose internal rotation, so now instead of having 30 degrees of internal rotation, they have 20 degrees of internal rotation, and basically the total arc is no longer 115, now it's 105. And then you lose 10 more degrees of internal rotation. Now the total arc is down to 95, basically. So that means we've got 20 degrees of what we call GERD. So that's a disproportionate change in the arc. It's transient, ending to ending, pitcher to pitcher, season to season. So it's not a reliable one-time measure, but it's an interesting measure to follow along. And if we have a lot of retrotorsion, then we will have more external rotation and less internal rotation. And this problem called, I shouldn't jump ahead too much, but it's called, if you have this internal impingement, which we'll allude to in a moment, where the tissues of the back get crowded, and you have not very much retrotorsion, a surgeon in France called Gilles Walsh, who's a friend of ours, he will actually cut your bone and give you more retrotorsion. That's how he treats, because if you have more retrotorsion, you selectively are protected from what's called internal impingement and probably protected from slap tears. So that's sort of opinion, but maybe statistically it's reliable. So that's how dramatic this can be, changing the torsion in the bone to treat the particular problem. So that can be a little confusion. This is professional pitchers with glenohumeral internal rotation deficit, GERD, display greater humeral retrotorsion. So this is now we've come all full through this on GERD, and this is what Chuck and Gang and Mike just published, showing that professional pitchers with glenohumeral internal rotation deficit, GERD, display greater humeral retrotorsion than pitchers without. So that's the answer to what we've been looking for. So now it's a publication. This is a dramatic input of our information in this. So that was one of the final ones we've just done that with the Rockies that is critical. So in summary, pitchers with GERD in the abdominal arm displayed an internal deficit. So now we've got a number on it of 15 degrees. Remember I said you lose, and if you lose 5 degrees of internal rotation, that's GERD, 5 degrees, that's not very much, that's probably good. If you lose 10, maybe that's not very much. But if you lose 15, maybe that's when it starts to become potentially injury threatening. And if it's a whole lot of GERD, then that's different. And so GERD could be muscular, so that might correct immediately with just a little massage. It could be soft tissue contracture, which really won't correct with that, but we can stretch it out with rehab and so on, which we do. Bony could play a role in that. So the conclusion was that pitchers with GERD displayed greater side-to-side differences compared to those without GERD. Now, here we are with Chuck and Ellen again, sort of looking at, this is the method of determining tightness posteriorly with crossed arm adduction. So you keep the scapula on the tabletop, and you take the arm and you bring it across the chest, and you can see this arm comes to about neutral. So Ellen's measuring when it comes, and Chuck's trying to keep the scapula flat on the bed. And if it doesn't come to neutral, that means there's tightness posteriorly. And this is a better method to measure posterior tightness than is loss of internal rotation. So this is crossed arm adduction. There are ways to do this. So Chuck and Ellen are pretty good at this, and this is also published work. So these are just some general comments at GERD, that how frequently it's present, changing season to season, changing within a season, And then pitchers with GERD, we've sort of alluded to, have greater humeral retrotorsion. And external rotation deficit concurrent, we haven't talked much about external. Chuck knows more about that than I'm willing to sort of talk about, because it does change some, but I don't want to confuse it, so we haven't talked much about that. So then this was one, Doug was involved in this, with humeral torsion as a risk factor for shoulder and elbow. Now we're saying, okay, so if you've got humeral retrotorsion, which is a lot, now we say, well, what happens? Do you get injuries to your shoulder, or does it protect the shoulder? Well, as it turns out, it's a predictor for elbow injury. So you have a lot of retrotorsion. That means you have a lot of external rotation. That means you throw the ball faster. That means you put more stress on your whole shoulder. That means you develop a problem, and the problem actually ends up being at the elbow. Those are the patients that get ulnar collateral ligament tears. So this retrotorsion and in the shoulder, it actually lessens their chance of injury. Lessens their chance of injury with slaps and internal impingements. So that's rather critical. We learned that. And so now that's why we have to understand retrotorsion in this whole complex. So, and this was just published. So again, this is a monumental paper, in our opinion, that our guys have looked at. So we asked the question, and we went to the data with our Rockies and answered the question and published a paper. So congratulations. And Chuck and the whole gang have been leaders. We have a whole team of people that do this, but Chuck and Ellen have been masterful people in getting these things done. Ellen is probably the most knowledgeable throwing person in adolescent children. She did a study just published on adolescents. Mike was involved in this, JT, Chuck, but they looked at instability in high school adolescents. So they had anterior dislocation of the shoulder. So Mike, he would say, well, I'm a military guy, so if you have a dislocation, I'm going to fix you right away. Why would he fix him right away? Because he's going to have recurrent instability, I guess. Well, what Ellen showed in her study was that what percentage of kids got back to throwing without ever having another instability episode? 75%? Yeah, so 75, 80% of them got back to throwing without another instability episode and good function. Well, that's a paradigm shift from what we've been taught. And that's because of the data we have. And that's Ellen's area of expertise, and she, I think, would be primarily responsible for that publication. So increased retrotorsion is protective against shoulder injuries, but increases the risk of elbow injury. So that's sort of where we've come with all these things. So protects the shoulder, increasing the risk at the elbow with ulnar collateral ligament tears. If you have an injury, as I said, to the ulnar collateral ligament at the professional level, the chance of getting you back to pitching is pretty good. But what we don't know quite well is, what about all the kids along the way in high school, single A, double A, triple, that have had ulnar and that has ended their careers? And that's a lot, probably. But it's if we choose an injury, that's not a bad one to choose. But we don't want to get a slap tear in the shoulder, and we don't want to get internal impingement, because if we choose to operate on that, it may well be the end of their career. We're not very good at operating on the shoulder and fixing those things, so we sort of shy away from that. So this is just showing on the left, this is an internal impingement area where the rotator cuff is torn. If you think about that, normally the rotator cuff tear is up here. This is posterior to the biceps by quite a bit. Leading edge of infraspinatus. So Doug's question is, what is the effect of these things on the pronator at the elbow? Because the pronator is over top of the ulnar collateral ligament. So the pronator sort of tries to protect the ulnar collateral and does a pretty good job. However, I've seen several pro pitchers that come in with an ulnar collateral tear and a avulsion of the flexor pronator. So if the force is dramatic, it can pick that up too. So the pathologies we see in the shoulder are internal impingement, whereupon there's degeneration and partial tearing posterior to the biceps, leading edge of infraspinatus, not where the classical near impingement tear is. So this, for example, represents one. We can see here that someone is trying to suture that down. Now, so this pitcher pitches with this, and it might be sort of adaptive. It may be something that helps him pitch, but sometimes even adaptive things can cross over into maladaptive. But somebody's trying to fix this. My prediction was, if that's fixed, he won't pitch anymore. He needs that to throw. But it can become pathological if it shifts too far. And then here is the slap tear at the top, and that impinges up here. And so if you fix slap tears, pitchers don't want to hear you fixing a slap tear. So you don't want to talk about that in the dressing room. Oh, we're going to fix this slap tear. They say, ooh, no, don't do that. So if you think about the pathological diagnosis, internal impingement, as you know, with external rotation abduction, the labrum, superior labrum, undersurface of cuff, and gets degenerative, that's the pathology that we see. And slap tears can occur. So Dougie and I, a number of guys, remember that Ellison guy, that Scott Ellerton? Did you read the book Where Nobody Knows Your Name about minor league pitchers? And nobody knows your name when you're a minor leaguer. It's a great book. One of our friends, Dougie and I, operated a couple times, Scott Ellerton, and he was up and down and up and down. Great guy. The other book to read too is by Jeff Passons called The Arm, and a pitcher went around and interviewed everybody about ulnar collateral ligament tears. You know, we've never done anything, although Ben Kibler might disagree, but he thinks differently. We've never reduced the incidence of ulnar collateral ligament tears. In fact, they're probably more common now than they were, and commoner in younger people. So we're not winning with ulnar collateral ligament tears. Fortunately, we're not too bad at fixing them. So if you think about these things, so now we have, this is a significant slap tear. This is a type 4 bucket here, V up into the, that's a big one. That's a beauty. But you look in pictures and you see these things. And then here's another one trying to be fixed. So do you fix this down, or do you put this down to there? Probably don't do anything. Now you probably have to do something with this. I don't know what you do, and I don't know how they're going to do. Yes. So in effect, it won't work, basically now. So we would just get rid of the biceps, just get everything right out of there. And then will a professional pitcher be able to throw without a biceps? Well, the answer to that I think is yes, but we don't have good data of numbers of those to say that. We have some pretty good college data. John Elway was a classic example back in '96, ruptured his biceps, threw better than he'd thrown in 10 years with no biceps. So it's a story that we tell, as you know. Brett Favre had his biceps cut by Jimmy, and he got back playing for a few years. So they're quarterbacks, so different than pitchers. So position players, they can play without a biceps for sure. I honestly think that a pitcher with this can't pitch. If you get rid of it, he probably has a better chance to pitch. So do we stabilize at the front? So I'm still of the belief that we used to, when Mike and Dougie and I examined these patients under anesthesia and they had a slap or an internal impingement, we would examine them to determine if they had increased anterior translation. Because in our opinion, when you see the normal pitchers, they don't have increased anterior translation. Now that's debatable. But when we get them to sleep and they say that goes too far forward, if that's the case, then we would tighten them up at the front. You used to use heat. That was Jimmy Andrews' study that heat people did better. And we threw the baby out with bathwater with heat. But now we put some sutures in there to tighten it down a little bit. So we would tighten down one who translated too far anteriorly under anesthesia if we're doing anything with a slap and a rotator cuff. I think that's the one thing where we can help professional pitchers, is making them tighter at the front. So these are the outcomes of surgery, generally speaking, and so players know this. Slap tear is poor, cuff repair is poor, anterior capsular tightening is okay, posterior release, almost never. They get tight posteriorly, but Burkhardt, Morgan, these people talk about releasing them posterior. It's hardly ever that we would consider doing that. UCL tears, and they fit into this situation, and we are fairly successful in a pro pitcher getting him back. And they're out for at least a year before they come back. So this is sort of where my thinking is in this. I think it starts with increased translation anteriorly in the shoulder, and when that goes farther, and you've got this consideration of how much retrotorsion do they have, and then we get increased stress on the posterior cuff, and we get tightness back there, and we get loss of internal rotation, and we're now getting into injury pain patterns. We get posterior shoulder tightness, which we have to deal with, so all pitchers prophylactically stretch their posterior capsule. So Chuck would work hard on all the players, teaching them a program. At the minor league level, they don't have a trainer to work with them every day. The pros do, so we have to teach them what to do, and we sort of set that up with the Rockies. They may get GERD. We usually sort of ignore it, but we have to certainly treat it with rehab. So anterior laxity, increased external rotation, Throwing shoulders usually have increased retrotorsion. This contributes to changes, especially in internal rotation. So GERD is that disproportionate loss of internal rotation, and the total arc is less. And we won't go beyond that. So treating shoulder problems, conservative, we just ride them out as long as we can. And the elbow, we almost jump on them now right away and operate. So this is our foundation team above. You can see all our nice people there. That's Tina and Cecilia, the two stars in the middle. They're smiling. Are they smiling? Smiling. And then that's this is our rat team. We look at rats. This is our throwing team. Chuck and Ellen are the mainstays. Tom Noonan in the blue shirt. And then Baker was one of our fellows. So we always have a fellow involved with us. And of course, Mike. So that's sort of the throwing team. This is a book we wrote on the overhead athlete. I've done about 9 books, but this one, Sumant Krishnan, came and said, we haven't had a book on the throwing shoulder for years. We need to do one. And I said, no, it's okay. He said, no, you invite your guys and I'll organize it. So from beginning to end, 9 months, he had the green book out. I mean, he's an accomplished guy, got it done, and edited chapters. So that's today about the best we can do.